Hello and welcome. Today I'm going to be presenting an assessment of a 66-year-old female who presented to the clinic today with some pain to her upper back for the last few days. She states all of a sudden she notices this rash that is itchy and burns. The rash is slightly painful and presents in a linear fashion. She does not know what to do. The symptoms are accompanied by lethargy and fatigue. 2 days prior to her presenting to myself here in the clinic, the patient experienced numbness and tingling to the same location. She's also unable to wear her bra. The patient explained to me that last night she did apply a heating pad to the area with some relief of pain. She also said that because the discomfort's so intense that she's unable to wear a bra. Right now she rates her pain at 5 out of 10. She said the pain was so intense last night that it actually woke her up. So she hasn't been resting very well lately. She had no recent environmental exposures and no recent sick contacts. So obviously if this was in a clinical setting, I would present myself to a room, wash my hands in front of the patient, introduce myself. Hi, my name's Eric. I'll be taking care of you today. And naturally, as we progress through the normal triage process in the clinic, patient will be asked to disrobe all clothing except the underwear. And we want to stay focused on not having any bra, any clothing on the upper areas because we want to inspect the back. So after doing my full review of the systems, we're going to focus on the back area where the rash is actually located. And as we do see a rash that's up to the upper left side of the back. And what we notice immediately is that this is a linear cluster of grouped herpetiform vesicles developed on an erythematous base. It doesn't run along the fifth intercostal space on the back right here, and it does not cross the midline. Also noted is that this rash runs along the T5 dermatome, and as I palpate it, the patient says that it is painful to touch, and when we do touch it, it does itch and burn. So my obvious diagnosis immediately after reviewing the patient's history, she did have varicella chickenpox when she was younger and has not received the varicella vaccine that we do recommend for patients over 65. So immediately my assessment is going to lead me to a diagnosis of shingles, herpes zoster. So with that diagnosis, what we want to do is do a complete head, ear, eyes, nose, throat, and neck assessment. And also included in that is the cranial nerve assessments, because as we know, frequently herpes zoster infections can affect the trigeminal, facial nerve, as well as the acoustic nerve. Back to head, we're going to start with skin of the scalp, and we want to make sure the rash has not traveled from the back area to any other parts of the skin. So we're going to look at the scalp, make sure everything's intact, and just what we're looking for is any rash within the hair parts. And you also want to look at the face to make sure there's no rashes in the face. First off, secondly, we want to go ahead and palpate the frontal and maxillary sinuses. So we're just going to hold the patient here. And this is the frontal, and then the maxillary. Any tenderness there? Okay, so that's good. So then we're going to move on to palpate the lymph nodes. We're going to first start off with the occipital, which is in the back of the head. So we're going to go ahead and just have the patient here. And then next we're going to go down to the post-auricular, which is behind the ears, so which is here. And then we're going to go ahead and move down to the pre-auricular, which is in front of the ears, right here. Okay, and then we also are going to do the tonsillar, which is behind both mastoid bones, so right here on the side. And then we're going to go ahead and go down to the submandibular, which is on the back of the chin, right here. And then we're going to go down to the submental, which is right underneath the chin. And then we're going to go ahead and we're going to focus on the anterior cervical, which is here on the back of the neck. And we're going to go ahead and travel all the way down this deep, what they call the deep cervical chain of lymph nodes. And we're going to go down to the posterior cervical lymph nodes. And then we're just going to go ahead and travel right above the cervical, the clavicle here. And we don't feel any lymph nodes. So after inspecting the head, we see there's no lymphatic involvement, which will rule out any type of infectious process within the lymph nodes. Okay, so the next part of the assessment is going to be the eyes, and we want to go ahead and first start off and inspect the skin around the eyes. So we're just going to go have the patient look at my chest. We're going to pull down lower eyelids. And what we're looking for is any redness, dryness, exudate, any signs of infection. So it looks pretty good. So the next part is that we're going to inspect a corneal reflex, and what we're going to use is a cotton wisp. And what we're testing here is the trigeminal nerve number 5, which is the reflex response, and then also the facial nerve number 7, which is the motor response. So we're going to go ahead and have the patient choose a spot up on the wall, and then we're going to come up on the side, and we're going to touch the cornea. And what we're looking for is the blink response, which we got. So that tells me that those nerves are intact. Also, what we want to look for is also inspect the pupils. We want to make sure they're equal, round, and reactive to light and accommodation. This is going to test optic nerve number 2. And what we're going to do, naturally, if we were in a doctor's office, we would turn off the lights. And we would go ahead and inspect both pupils, make sure they're reactive. So go ahead and look up here. Okay, good. And as we're inspecting the eyes, what we're doing for accommodation and sorry.
You're good.
When we're looking for reaction of the pupils, we want to look for a consensual response on both sides of the eye. So if we're looking at the left side or the right side, we want to see that same response in the opposite eye. So the next step was that we will test the extraocular movements in the 6 cardinal positions, and this is going to test cranial nerve number 3, oculomotor, as well as cranial nerve 9, the trochlear, and cranial nerve number 6, the obtusus. And what we're going to do, go ahead and have the patient look at the tip of the pin and keep the head straight, and we're just going to go across. And as we're doing this, we're just looking for any nystagmus. And we're going to go up and down, and then back to the midline, and then down and up. Good. So it looks pretty intact. Okay. And then also what we want to do is perform what we call the peripheral vision test, or confrontation. And we're going to go ahead and have the patient cover one of the eyes. And what this test is, cranial nerve number 2 was also the optic nerve. So what we're going to do, we're going to stand over here and we're going to check the peripheral. Can you see that?
Mm-hmm.
Right here?
Mm-hmm.
And right there?
Yep.
Okay. And back here?
Mm-hmm.
Okay. Go ahead and cover the other eye. We're going to come on the opposite side. We're going to do the same thing. Up here.
Mm-hmm.
Down here.
Mm-hmm.
Down here.
Mm-hmm.
And down here.
Mm-hmm.
Okay, good. So upon assessment of the eyes, we look like everything's intact. And so we're going to go ahead and move on to the ears. First off, when we're going to look at the ears, we're going to look around the external ear, and what we're going to look for is color, texture, integrity, tenderness, and drainage. So we're just going to look at each ear. Everything looks good. And obviously we're going to ask the patient if they've had any ear pain since the development of the rash. So we're going to look in both ears. Okay, good. Everything looks great. And then also we're going to do the finger rub test, which also helps assess the cranial nerve number 8, which is the acoustic nerve. So I'm just going to come up, rub my fingers. Can you hear that?
Mm-hmm.
Go on this side.
Mm-hmm.
Okay, good. And then we're going to go ahead and inspect the internal ear. With our otoscope that we'll have, we're going to approach the patient on both sides. We're going to do this bilaterally. We're going to pull up the auricle of the ear, and then as we insert the speculum, we want to go ahead and slightly down in a slightly downward angle, and then we're going to look at the ear, look at the eardrum. We want to make sure that we see the cone of light. And what we're looking for when we're inspecting ears with an otoscope is for any signs of infection, any fluid behind the eardrum, any bulging of the eardrum, and as I said, we want to make sure that we see that cone of light. It's not going to be uncommon to see any earwax or dry skin within the ear, but basically what we're looking for is any type of infectious process within the ears. The next step, if we want to go a little bit deeper into the testing of the ears, is the Weber test, and this will be done with a tuning fork. And what we'll have is a tuning fork, and I'll tap it on my thigh, and I'm going to place it right in the middle of the patient's scalp, or in the middle of the head, and I'm going to ask them if they hear the vibration on both sides. Can you hear the vibration on both sides of the ear equally? Okay. Now, if there was any deviation from that test, then we actually would submit the patient to go have further testing of the hearing. Another one is called the Rini test, and this is also done with the tuning fork. Again, what we're looking for is air conduction versus bone conduction, and we should have the patient here with, it should be, the air conduction should be greater than the bone conduction. And again, I would take my tuning fork, tap it on my thigh, and then I'm going to put the tip of the tuning fork, the bottom of it, right here against the mastoid bone. And then we're going to ask the patient when they start hearing the vibration. So can you hear it?
Mm-hmm.
And then we're going to ask the patient once the vibration stops to note that it stopped. Has it stopped?
Mm-hmm.
Okay. And then we're going to take the same tuning fork and we're going to put it right outside the ear. And we're going to ask the patient the same thing. Can you hear the vibration?
Mm-hmm.
And then we're going to have the patient nod where they don't hear it anymore. Okay. So that's going to go ahead and test the air conduction versus bone conduction. Okay. And upon inspection of the ears and doing the test, the ears are intact. So the next part of the exam is going to be inspection of the nose. And again, we want to look for the integrity of the mucous membrane, the skin around the nose. So I'm going to go ahead and just look and ask the patient if there's any tenderness around the nose. Go ahead and lean your head back. And with the flashlight, I'm just going to look up each nostril. And what I'm looking for is any deviation in septum, any redness, any signs of infection. Okay, everything looks good. And then also we want to go ahead and do the test for cranial nerve number 1, which is olfactory, which is the sense of smell. And you can simply do this by opening up the alcohol wipe. Let the patient, can you smell that?
Mm-hmm.
And the patient can smell it. So one thing when we're inspecting nose with a shingles infection is also what we call the Hutchinson sign. And this is a rash at the tip of the nose. That's typical sometimes with people who do have the shingles infection. And what this entails is the virus involvement of the trigeminal nerve, which is the cranial nerve number 5, which is one of the main cranial nerves that usually is affected with a shingles infection outside of the typical rash that we see that travels along the dermatome. Okay, the next inspection is going to be the throat and mouth. So we're going to go ahead and have the patient open up their mouth. And what we're looking at basically is that we're looking for integrity of the teeth, the cheeks, mucous membranes. We want to go ahead and make sure that we look at the hard and soft palates. We want to go ahead and have the patient say ah, so we can look at the uvula, make sure it's midline, no deviation. And obviously if this patient still have their tonsils, this patient did have a tonsillectomy when they were a child, we would look for any signs of infection on the tonsils. And then we also want to look at the pharynx too. So the next step would be to inspect the presence of a gag reflex. So actually we would take a tongue depressor, a wooden tongue depressor. I'm actually not going to do this with the patient, but what we're testing for is cranial nerve number 9, which is the glossopharyngeal nerve, cranial nerve, as well as cranial nerve number 10, which is the vagus nerve. So I would go ahead and have the patient say ah, and I would put the tongue depressor on the back of the tongue, and that would elicit a gag reflex. Also, when we have the patient inspecting the tongue, we also want to make sure that's in midline. So go ahead and stick your tongue out. We want to make sure it's in midline, good position. Go ahead and turn your tongue that way. Okay. We got good position, midline position, and good strength in the tongue. And what this is testing is cranial nerve number 12, which is the hypoglossal nerve. If we want to further test the cranial nerves of the throat and mouth, we can inspect taste, which would be cranial nerve number 7, which is the facial nerve, and cranial nerve 10 again, which is the glossopharyngeal nerve. But we go ahead and ask the patient any changes in taste in food. Okay, so we're good there. So the next step is that we want to observe any the facial movements and make sure that they're symmetrical. This is going to test trigeminal nerve number 5 again, and cranial nerve number 7, which is the facial nerve. So we're going to go ahead and have the patient smile. Go ahead and frown. Okay. And then we're going to go ahead and puff your cheeks out like this. There we go. And wrinkle your forehead. All right, so that's intact. So we also want to go ahead and palpate the tongue strength. And so we're going to go ahead and demonstrate to the patient how we want to do this. So go ahead and take your tongue, push it on the side. We want to test that strength. Push up, and on this other side. Okay. And then what we also want to do is the sternocleidoid mastoid strength in the neck. So we want to go ahead and have the patient push against my hand. So turn your head. There you go. That way. And then we're going to go that way. Nice strength. And what we're testing here again is cranial nerve number 12, which is the hypoglossal. Okay. Next part of the assessment, we're going to go ahead and assess the neck. And that starts with an inspection of the skin around the neck area. So we look and make sure that the actual rash that she's complaining of is localized to the back area and has not progressed up to the neck area. So everything looks good. So we're going to stand in front of the patient, and what we're going to do, we're going to look at the trachea, make sure it's midline. And what we're going to do, we're going to take one finger and we're going to run it down along the trachea. And we want to look at the space between the sternocleidoid mastoid muscle and the trachea. And it should be one finger each side. Okay, good. And then we're going to come back behind the patient, and we're going to tell them that we're going to be putting our hands around on their neck and throat area. It might be uncomfortable, but we're going to go ahead and warn the patient that we're going to do this. And what we're going to do is check the thyroid for any masses or nodules. So first we're going to go ahead and just start at the top, and we're going to work our way down. And what we want to look for is the cricoid cartilage, which is going to be our landmark, and it's right there. And then we're just going to make our way down to the thyroid isthmus and go ahead and have the patient swallow. Okay, and as the patient swallows, we want to look for any deviation of the thyroid, see if it moves to each side. It should be midline, no nodules, no masses. While we're also standing behind the patient, we want to go ahead and have them do a shoulder shrug. This is going to test cranial nerve number 11, which is the spinal accessory muscle nerve. So what we want to do is place both hands here on the patient and have this shrug up, press up. Nice strength. Okay, go ahead and relax. And what this is going to test is the strength of the sternocleidoid muscles as well as the trapeze muscle. And as I said, that was cranial nerve 11, which is the spinal accessory nerve. Also, when we're at the back, we want to go ahead, and since she is complaining of back pain, we want to make sure there's no deviation in the spine. Muscles are nice and intact on both sides, and everything looks good. So upon conclusion of my assessment of the patient, we did head, ears, eyes, nose, throat, and neck. I can further conclude that this is actually a herpes zoster infection. As we further go through the full physical assessment and look at the fact that she did have varicella when she was a child, and she has not received the varicella vaccine that we do recommend for patients over 65. And as we go back and look again, just to determine, the actual dermatome is T5, and it tracks along right along the fifth intercostal space, and it also doesn't go across the midline. Okay. All right, thank you very much. My full physical assessment, along with history, my assessment and plan for this diagnosis will be included with this video. Thank you.